Thank you for joining us today for a DCS webinar on using existing discharge processes to springboard care coordination efforts. Our presenter is Tim Perkins, co-founder of DCS. Tim is responsible for leading our care coordination strategy and client delivery for all our engagements. Tim, take it from here.
Thank you, Laura. Good afternoon, everybody. The name of this webinar is Using Existing Discharge Processes to Springboard Care Coordination Efforts. We are going to discuss, very simply, the fact that care coordination is here and that it's not as big and scary as one might think. It doesn't require a huge investment and effort to get started, especially in new technologies. You can get started right now with what you have. We're going to talk about how to extend and leverage your existing discharge process as the place to start to best support the transition and care efforts to your post-acute patients. And also we're going to talk about what that means in terms of reducing readmissions, improving quality of care, building brand loyalty, and improving physician relations without breaking the bank. So all these things can be achieved for not a huge investment and not a lot of money. So we're going to review some best practices around improving discharge processes and discuss why that's the best place to start your care coordination efforts. We're going to talk about some good methods to align your care team around the improved discharge messages, and not just within your organization, but across organizations. We're going to talk a little bit about how you get started and how you document your current discharge processes to identify the top breakdowns, be able to measure them, be able to build the business case in order to make the changes and the improvements, and then how to measure those improvements and make them stick going forward. A little background on DCS. We do consulting and services with healthcare organizations around how to better do care coordination, collaboration with others, and also communications. A big part of this is communicating, educating the other providers, the other people in the care team, the patients, etc., on how the best work together, what the benefits are. So we combine a series of disciplines in order to improve your patient-provider engagement that delivers measurable outcomes to the organization. So those of you who remember Bob Dylan, especially before he went electric, one of his biggest hits was "The times they are changing." And if you're in healthcare, then that is very true today. The time is changing. There's a variable number of items going on here that are coming together, a confluence of events that are changing healthcare as we know it, for better or for worse, depending upon who you are and where you stand. But the changes in payment and changes in technology and the changes in some exciting new treatments coming in all the time, it's a very, very dynamic field. We're feeling it. I think everybody's feeling it. The old fee-for-service model, while it had its benefits and its negatives, it is sunsetting. It is going away. It's had its day, put it that way. New payment models are coming in fast, and those change everything. How you get paid changes how you behave. So these new payment models focus predominantly on episodes of care and also longitudinal care through capitated payments. So things like bundled payment will pay you X amount per hip, per knee, and it's starting with the more predictable procedures, but you'll soon see it extend, the reach get bigger and wider. So you've got bundled payment, very straightforward, but it's around the episode. It's not just about, it's about the PCP, it's about the specialist, acute care, post-acute care. You think about a hip and a knee, OT, PT, rehab for a couple of days, everything goes well, every patient does well, good patient outcome, and a good financial outcome for the provider. We get paid for performance as well, which is a modified version of bundle payment and capitation and risk. Capitation per payment, per patient per month. That's a little trickier because your goal there is to keep your patients healthy and away from specialists and eventually away from the hospital, and to keep them happy and healthy, and you'll make money. And then you get shared savings variance, which risk, full risk, half risk, all kinds of deals going on. But the net is payment models are changing. That's impacting how treatment is allocated and how the efficiency and effectiveness of delivery need to improve if this is going to work. Another thing you've got to realize is that regardless of where you are in the system, whether you are a acute care, subacute, OT, PT, visiting nurse, pharmacy, wherever you are in the system of delivery of care, you can no longer think of yourself as the isolated center of the universe. You have to share. You have to start thinking episodic. It's about the patient episode, not just about what they do in your delivery room. So you begin to think beyond the encounter to the episode, and then eventually beyond the episode to the longevity, the longitudinal record of the patient over time. So you've got penalties and incentives. They're impacting acute care. 30-day readmissions is a good example. But in 2017, it starts going out into nursing homes and SNFs. So that's beginning to impact more than just the acute care. So everybody benefits from timely exchange of clinical data, right? You need to coordinate better. And if you don't, then you're going to feel it. The new payment models will make this painful obvious. So just a quick study, a third of physicians don't consistently notify patients about abnormal test results. It's just, even though the technology is there, these things aren't happening. A quarter of referring physicians don't receive consultation reports from a specialist 4 weeks after the consultation visit. So I refer somebody out, they go out to a specialist, I don't get the results for 4 weeks. Something not right there, especially if you're the one doing the referring. And over half of PCPs aren't giving information about the discharge plans of the recently hospitalized patients. So when we talk to people, talk to organizations, especially acute care, we always ask them how quickly does the discharge summary go out? How do they go out? How often do they go out? And it's an amazing amount of time. They do not go out fast enough to make any difference, to be actionable, to make any difference in the follow-up visit. If there is a follow-up visit, because half the time the PCP doesn't know that the patient was in the hospital in the first place. These are the basics where we can begin to implement coordinated care. It doesn't take a lot extra. The data is there. It doesn't take a lot of extra effort to tie these together. And the point here is that it's in everybody's benefit, especially the patient's. The patient comes first, but it's in everybody else's benefit as well, especially the patient, in order to coordinate, communicate, and share information. We talked about the webinars being starting at the discharge point. Why are we saying that? Well, it should be painfully obvious. It's your most logical point of transition, whether you're sending a patient, receiving the patient, especially if you're a rehab or subacute or a SNF, or monitoring. Now, you might say monitoring. Why would I want to monitor? Well, if you saw the first two slides, you know that you're no longer the center of the universe, and your payment is being tied to how well that patient does, the patient outcome on the episode, or if you're a capitated model or full risk model, how that patient does for the rest of their life, in essence. So if I'm going to put all my eggs in one basket, the saying is, watch that basket. So if I'm on an ACO or a capitated payment model, and I have a patient that needs to go in and out of the hospital, I want to know about it because it's coming out of my hide, essentially. So I want to make sure that that patient is getting the best care they can get at a reasonable price. Make sure things are followed up on, that I don't miss this opportunity for them to have a good recovery and to stay out of the hospital or the rehab, or stay in the long-term facility and not have to get readmitted back to acute care, etc. There's 100 different reasons why. Monitoring is becoming more and more important in this game. So why are we using discharge? That's where accountability and responsibility for the care is being transferred between the health entity. That's where the handoff is. This patient is now your primary responsibility in the ambulance or out the door to home. They're being discharged to home. So all that information and that responsibility should be transferred together. It's also the place where, according to the Joint Commission, this is the root cause of ineffective transitions and transactions take place. This is where a lot of the screw-ups happen during this event. So this is the logical place to start because, like Willie Sutton said, you rob the bank because that's where the money is. You start at the discharge because that's where the coordination, communication happens and also breaks down. So let's start there. Let's get that right. Lots of opportunity there. We talk about the problem at discharge. Just want to talk about it a little bit more so people understand what we're discussing here, what we're talking about. At discharge, Joint Commission identified these three areas: breakdowns on handoffs. So the patient, the care providers don't communicate among themselves. They don't communicate to the patient or to those taking care of the patient. This doesn't happen early and often enough. There's a lot of problems there. Communicating, the communication method, the discharge instructions, the discharge summary, the packet that goes with the patient. Oftentimes they're conflicting, they're contradictory. Sometimes they're not filled out. They're not filled out well. They go out too late. The patient doesn't understand them. They become ineffective. They become another thing for the patient to carry out that they never read. One of the main ones, interestingly enough, is that when they looked at individual handoff situations, transition situations, and they interviewed the senders and the receivers about what they thought they were giving and what they wanted to get, that there was a fundamental mismatch between the expectations of the senders and the receivers. This was an interesting finding, and it is something that you need to think about, dig into a little bit deeper. So we have these differing expectations of senders and receivers and handoffs, and the fact that discharge summaries reach the primary care provider by the time of the first follow-up visit only 12 to 34% of the time. We think that's amazing. So where do you start? How do you get started? Well, we recommend a couple of things. We recommend this approach. We think that what we call the quick six. We think there's 6 things you can look at right now for immediate impact. You walk into almost any organization and say, look, let's look at these 6 things, and there'll be something in those 6 things that's going to right away improve your care coordination, improve your communication, and improve the outcomes to your patient, and in turn your financial well-being. And then there's the strategic things. These are things that can't be done right away. You really need to talk about them. You need to discuss them. They need to be discussed with your management team. They may take a little bit different direction. It could be cultural. Business case needs to be built. So we recommend you get started with the quick 6, and then you start the strategic 6 in parallel. And I'll show you how to figure out which 6 to do and how to think about those strategic 6. So here's the quick 6. We're going to go into each of these in detail. PCP coordination, follow-up, discharge instructions, family coordination, meds at discharge, patient education, home health, OT, PT coordination. If you're into discharge, you're kind of going, yeah, so what? Well, we're going to look at it a little bit differently. We'll get into it. First thing is, what's the approach? Well, we believe in getting started. You can talk about it forever, but you just got to dive in. You just have to do it. So we would say, well, to pick your top 3 and dig in. I could probably sit in a room with 4 or 5 people who really understand these processes in detail, and then within 45 minutes, really kind of come out with the top ones to look at first. If you're in doubt, we can do a little quick measurement, but we pretty quickly look at the 6 and go, you know what, this one's going to give us the biggest return right away. Then what we do for each one is we do a quick as-is, a quick review, a quick flow chart. What happens here? What are the handoffs? Who does what to whom? How long does it take? We do a thing called the value process map. I'll show you a sample of it in a second. It's not that difficult to do. It really isn't difficult. Actually, it's pretty simple. Show you an example of that. And that's really going to help you dig down and understand. Here's what happens inside the process. Here's the handoff. Here's how long it takes. It really serves as a basis to understand process, but also serves as the place to understand what the opportunities are to make the process better. Okay? So we identify the as-is. We do some measurement. We measure the impact of the actions. Here's what it's costing you today. Here's the time it takes. Here's the quality of the patient outcome. Here's a missed opportunity. They become pretty self-evident once you dig down into the process with the people who know the process and live the process, not the people who are 2 or 3 steps away from the process and will give you a theoretic understanding of the process. We want the hands-on folks that are doing the work. That's where the breakthroughs occur, not the people who say, this is how I think it happens. The people who say, this is how I know it happens. So it's not just something you can do with the manager. You got to do it with the people who are doing it. Okay? So, what are changes? What you're going to do through that process is going to be amazing. You're going to find there's a whole bunch of things that we can change. Small things, big things, fundamental things, simple things. Whole combination of processes you can put into place. Sometimes technology plays a role. Many times it doesn't. So running to technology as the answer isn't the answer. It's understanding and holistically understanding the impact. If technology is a part of the solution, great. If not, even better, because you probably get things done a little bit faster. Pilot the impact, keep measuring and adjusting. It's a commitment to say, we're going to make this better. We're going to try some things. Some things are going to work. Some things aren't going to work as well. We're going to make a commitment to change because we know that staying the way we are is not a recipe for success. And then after you've piloted, you've worked out some of the kinks, you take on the challenge of scaling. How do I get this across the service in the hospital? How do I get it across the organization in a nursing home? I might start in one wing. I might want to go to another wing. How do I get this across my entire visiting nurse organization? What's it going to take? Nurture it, scale it, understand it, then you can scale it. And then always you're measuring and adjusting, and you're always looking for ways to improve. This is the fundamental mindset you've got to embrace. Otherwise, things won't get better, the patient outcomes won't get better, your financial returns are going to get worse, and it's a spiral. This is an example of a process map. This is just very straightforward, and really all you're doing is you're saying, okay, this is the discharge process. We say, okay, how does it start? What happens? Who does it? How long does it take? You fill out a form. How long does it take you to fill out the form? It takes you 5 minutes. Okay. Then what happens to the form? Walk me through. Where's the form go? Who gets it next? How long does it sit on their desk before they do something with it? Do they batch them up and do them all once a day at the end of the shift? Do they do them as they come in? It's very simple process, interviewing process, to break down a process, handoff to handoff, step by step, dig into it a little bit, begin to measure it, and then you start understanding, even though a form might take 5 minutes for you to fill out, 6 other people need to touch it. It takes each one of them 5 minutes, but on average it sits on their desk for an hour and a half. So even though something might take 30 minutes to do, it might, in elapsed time, take 6 or 7 hours to do because it's sitting on people's desks. So, all right, so is there a reason to shorten it? Do you want to shorten it? How do you do it? That's a very basic example. But understanding the value process map of a step, breaking it down, very straightforward stuff, but necessary to understand what's going on. It really begins to open your eyes and get people on the same page. There's a series of tools like this. Flowcharts and value process maps happen to be 2 of my favorite because you can get people in a room, do them relatively quickly. You get a lot of bang out of the time invested. So then you apply them against things like this. PCP coordination and follow-up. This is my favorite quick six, because you'd be amazed, and maybe you wouldn't, depending upon where you are and what you do. That do you even know who your PCP is? Is the PCP getting notified? Are they getting notified? What's going on? You'd be surprised how many times they aren't, especially in a highly hospitalized acute care facility. People come in on their own, they leave on their own. They're coming into the ER. You don't even, sometimes you don't even know who the PCP is. So here's your first question. Do you know who they are? Are you sure? There's a name on the face sheet. Do you know if the name is correct? Do you know if the name is current? You may even ask a patient, is Dr. Jones your PCP? Depending upon your stratification of risk, and if you've done LACE scores, the patient might not be able to reliably tell you. So when was the last time you tested your face sheets? That patient came in and you called the doctor's office. You looked at the phone number on the face sheet and actually tried the phone number, because many times you find those phone numbers are incorrect, and you actually had someone call the physician and say, "Is Mrs. Jones your patient?" And if so, hey, they've just been admitted. So how are your face sheets? Are they accurate? We've done some quick ones, and we've been surprised at the amount of inaccuracy on the face sheets. So this is number one: is data there? Is it effective? Do you notify PCPs of events? Is that part of your regular process? And if so, which events? Is it just admissions? Is it just discharges? If you send them a discharge summary 3 weeks after they've been in the hospital, then yes, you're notifying them of the discharge, but you're doing it 3 weeks after, 21 days into the 30-day readmission period. I doubt that's doing much good, besides documenting the fact that they're in the hospital. Do they know an admission? Because there could be things that they could bring to the party that you don't know, because theoretically you don't know the patient as well as they do. Are you notifying them of procedures, med reconciliations? Are you inviting them into your system? That's something some people do. Are you pushing a set of data their way on discharge, right? So how and when do you notify? Is it phone? Is it text? Is it email? Do you do any of these? Do you have any of that information for the PCP? What data do you provide? Do you automate it at all? If so, from which systems? How often does it go out? And you have the ability to have the PCP do feedback in more than just a, hey, I noticed, I saw that, I got to give them a call. That's always good, but that doesn't always happen. So can someone from their office get back and give feedback to the team treating the patient in a timely manner so some of that information can be actionable? Very straightforward. We dig into one of these, one of my favorite quick six. I think we could do more positive good for everybody just on this item if it's really handled well. And it's amazing how many people don't do it. It's amazing how many people who do it don't do it well. So this is my number one of my quick six. Discharge instructions and summaries on the other end. Talk to residents at large teaching hospitals, and they'll tell you that the discharge instructions don't look good when they go out. Are they there? Yes. Are they a part of the discharge process in the EHR system? Yes. That still doesn't mean they're filled out. That doesn't mean they're filled out well. So you could say, yeah, we do discharge instructions for everybody. Well, okay, in the part of the electronic record, yes, they are. That's the good news. How often are those audited? How often are those actually reviewed? How often is feedback actually given back to the attending or whoever wrote the discharge instructions to say, are they of high quality? Or are they just a boilerplate paragraph, perhaps, if anything? Who are they shared with? I'd like to see, the instructions and the summaries. What is your process on summaries? Do they go out? How quickly do they go out? How do they go out? Are they, how are they vetted? How are they checked for quality? Very simple to check, but there's an assumption going on these things are happening, but there is no assumption going on necessarily these things are happening well. always pays to go back and really dig into this and really look at it. Can you fill out this grid? Can you tell me? I could tell you theoretically that a family's getting instructions and that the PCP is getting summaries. How about home health? Do they get summaries? Do they get instructions? Do they get instructions if they're being put out to a visiting nurse to follow up? What are they getting from the facility? And how about OT? How about pharmacy? Are the different players in the well-being of the patient, are they getting this information? If so, what information? How are they getting it? Where are they getting it? And is it automated in any way in order to take some of the labor out of it? And can they feed back? And they say, you know what, something here is not right. Especially pharmacy, they're really adept at spotting, especially with MedRex or something that's a little odd. So, discharge instructions and summaries, my second favorite. Family coordination. There's no getting around this. Approximately 80% of patients in acute care are discharged to home. If you're in a SNF or an LTD, LTC, long-term care facility, now you're talking about family coordination through the facility, but there's still information that needs to come through and be coordinated. And we all know that good family support means a lot. It means getting the people to the right meds, getting them to appointments on time, OT, PT, keeping an eye on the patient. A lot of places where the family become an active member. There's also a lot of cases where the family is not an active member and they aren't into the process as much as they should be or they would like to be. So what are you doing for family coordination? Are you doing risk assessments? Are you stratifying? Are you trying to understand those you don't have to worry about because you know they're going to be taken care of and the families come to pick them up? Are those that are cognitively fine, who understand the instructions and understand their own care, as opposed to those who don't hear as well or have mild cognitive issues? They don't really understand, even though it looks like they do, and they're nodding. All of these things. Is there a competent family caregiver? Do they understand their role? Some places will have them sign a care plan and say, I understand this is what I have to do. If there's no caregiver, what's your fallback plan? What's your plan B? Do you have home health, community-based, that you can fall back on? Home health that insurance will cover. This has gotten better and better over the last number of years. Plan C, community, church-based in many parts of the country. Have those been identified in the intake process, in the assessment process, especially the risk assessment? And then with the case workers and the social workers, what's out there? How well is your organization tapped into the community so that you know what's out there, so you can assign and or make the patients aware of resources available to them so that the family coordination can get better. There's a lot of pieces to this, and this is a continual issue. This will never go away as long as we're dealing with people and we're dealing with families. So it is an area that needs sustained focus to make an impact. However, it's worth it because you can make the impact with the patient gets the right care, everybody makes out good patient outcome, good financial return, and the patient's well cared for. Family coordination, another rich area to explore right out of the gate, right off the discharge process. Meds at discharge, again, medical mistakes hurt 1.5 million patients a year. It's the number 2 reason people come back within 30 days because they aren't taking their meds, they're taking their meds incorrectly. They leave the hospital with a sample for 2 days, and then they can't get to the pharmacist to get it refilled. We all know there's a lot of research on this, so it bears focus. What are you doing with the MedRecs? Are they shared with everybody that they need to be shared with? Does the patient understand the MedRec? Not the patient, the caregiver who represents the patient. Are they leaving with the meds they need? Are they getting at least a 30-day supply when they leave your facility? How does that work within your facility? Some places have a meds to beds program. Sometimes it's very restrictive. Sometimes it's 24/7. Sometimes they close at 5. And if the patient leaves at 6 or 7, they're not getting their meds. If they leave on the weekend, they're not getting their meds. How do you address that? Is it worth it? Is there a business case that says it's worth it to have the pharmacy open 24/7 for these people to go home with their meds, so you can make sure they're getting at least 30 days of appropriate meds? Again, teaching. Do they understand the meds? Big part of the teach back. There's a lot of things that can be looked at here in meds at discharge. Again, very simple to say, but when you start digging down into what's being done today, what could potentially be done, and then making that change, it's one of my quick 6, because usually what people think is happening, especially up at the senior and operational level, and what is actually happening down in the trenches are two very different things. And so how are you measuring it? Another rich area where impact can be made right away. Patient education and follow-up. This kind of goes with family coordination, but I did separate them because it is a little bit different. Is the patient understanding their condition? Do they understand what they can do? Some facilities are getting more into video delivery of information around certain chronic diseases. As we all know, there's a very high percentage of Medicare, Medicaid folks with 2 chronic conditions: diabetes, chronic heart disease. If we know these are the big ones and the high volume ones, what kind of information do you have that you can pass along to them? Some people are using iPads to deliver a custom package of information and education while the patient is in the hospital. Some places have hospital channels. Bunch of different ways to do this. I think it's fascinating that while people in the hospital will say they understand the discharge instructions, they really don't. And the study on the right-hand side here is one of my favorites. People over 65 years of age. 40% were unable to accurately describe the reason for their hospitalization. Because after you went in, you said, this is why you're in the hospital, this is what you're suffering from. They nod their heads, they say yes, they tested them later. 40% couldn't even tell you why they were in the hospital. And over half of them couldn't recall instructions about their follow-up appointment. So we know that there's something going on here, that there's a lot of room for improvement. So how do we address? Okay, there's a lot of room here. How are you doing it now? What can we do to improve it? Why improve it? Well, patient education is very important in keeping them out of hospital, 30-day readmissions. If the patient is incapable, then how do we go back and impact the family as well? Family caregivers. What kind of resources can we give them? What can we hook them up with online? Is there a caregiver packet that goes out to them, which is a little bit different than the patient packet? A lot of things that can be done here. Again, a target-rich environment for improvements. And then the last of the quick 6 is home health OT-PT coordination. When a patient goes out, how often does the patient go out to the same visiting nurse? If you have an acute care organization and they're going out to home, do you know who they're going to? Do you know who the visiting nurse organization is, for example? Do you know who the home health organization is? Do you have a relationship with them? Do you do a lot of work with them, or is it sporadic? Or do you have a lot of home health aid because of either the size of the organization, the geographic area in which you cover? It doesn't really make sense. What's your relationship with them? How much outreach and communication have you made to your network that impact your life? You no longer being the center of the universe. So who else do you rely on? Who do you rely on out there for OT-PT? Is it in the home? Is it in the facility? Who are they? Do you know them? Do you know that they do good work? How do you share information with them? Okay, what do you get? What do you send them? What do you get from them? What do you give to them? What kind of information flows across? That's not just on a piece of paper or on a discharge instruction, which may be poorly written to begin with. Okay, do you share and communicate today? If you do, how do you share and communicate today? Have you made the effort to say, here's the people that we want to deal with, or here's the people that we want to go with? So we want to make an extra effort with this network of individuals. A lot of things that could be done here. You got to start putting together your network, not an informal network. You've got to begin to formalize the communications a little bit better, so that when traffic and patients come over the line, it's already you're not reinventing the wheel. So this also goes for community organizations. It extends beyond your network. It goes out of network, and it also goes out into the community. So what are you doing to reach out there and connect? It's more than just a meeting once a month. How are you aligning your processes? So there's a lot of work that can be done here, and frankly, this is one spot where some web-based technology appropriately put together and in a secure fashion really can pay dividends. But that's in a certain set of circumstances. A lot of things that can be done here, but this is one of the big ones. It's one of the quick six. I guarantee you walk in with these 6 things, you go through them, you're going to find stuff right away. If you're looking for a way to make changes and a place to go first, start with discharge, start looking at these quick 6 things, you're going to start making an impact right away. Meanwhile, you're looking at strategic items. Strategic items, you can't just walk in and say, okay, let's take a look at what you're doing to notify PCPs or what you're doing for OTPT. You've got to take a look at these in a little more thoughtful, longer-term manner. Can you realign your operations to the new patient-centered episodic reality and payment models? Where are you now? What are you doing now for fee-for-service? Can you make the leap? If so, what do you need to change? Have you studied that? Have you looked at that? We'll talk about these a little bit more. Who owns the coordination process for your organization? Should you look to technology to improve the automated exchange of information to support coordination? Does it make sense for you? How do you better leverage the network you have today? You have a network today. Can you identify it? What shape is it in? How do you improve it? Should you step up and be the coordination anchor facility for your network? Is that you or is that somebody else? And if so, how do you get them to step up? And are you really building a true community of coordinated care? So, can you align your operations to the new patient center? Fortunately, a lot of it's about the money. Follow the money. Fee-for-service is going away. Episodic is here. So your operations are going to have to assume more risk. They're going to have to become more efficient and effective. And are you committed to better communication, what's called across the continuum of care? If you aren't, then you're in a vulnerable spot. If you so this is a strategic question. Are you willing to change? Can you change? And if not, then you're going to have challenges. If coordination is important, as we believe it is, then the fundamental question is, who owns it? Who owns it in your organization? Do you know, if you own it in your organization, do you know who owns it in your partner organizations that you do a lot of your work with? Do you know who owns it across your larger physician groups that you deal with? Do you know who owns it in the SNF? Or if you're the subacute, do you know who owns it in the acute cares that you receive business from? Now it's time to map it out. Start mapping out who owns that coordination process. And that's a strategic question. Who owns it? Do they have the authority to do something to get the job done? And as Milton Friedman said, if everybody owns it, nobody owns it. Nobody has a direct interest in maintaining or improving its condition. So if you walk in and everybody says, we all own care coordination, yeah, to some extent, but if it belongs to a committee, in effect, nobody owns it except the committee, and committees are busy doing a lot of other things. So think about your data strategy, think about your technology strategy. What's it doing today? If you are an acute care organization, you have an EHR system in place, you have spent a lot of time and a lot of money um, working on your facility. Great. If you're an IDN, then you've worked on your facility. You might have ambulatory packages for your physicians when they're seeing their patients. You could have extended. So now you've got great visibility across your institution and across your providers as an IDN. So your primary, your PCPs, you know who most of them are. They can look directly into the EHR, so they're getting great care coordination. Great. How about outside of that, right? How about out of network? How about in the community? So how are you applying technology? We don't believe it's the first thing you should run to, but if it's a part of the strategy and part of the process and it's supporting it, then it makes sense and you can make the business case for it. Right? All depends on how big your network is. And then we don't believe in jumping in. You've got to know your facts, build the case, build and scale pilot. We're big believers in that. It's realistic. So as I was just talking about, you have these concentric rings. You get your facility, your network, people out of your network and community. If you're a hospitalist, acute care facility, and you don't really know who the PCPs are, and they don't have access to your EHR, then they're out of network. They're sitting out there. You've got to get to them. How do you get to them? How do you push information to them? Is there a place you invite them to come back in and share information? And then it gets even broader when you get out there into the community. So can you better leverage your network? Do you know what your network is, first of all? Have you mapped that out? And then, so there's a whole strategy here of here's the people that we need to rely on and to depend on in order to succeed at care coordination. Do we know who they are? And how do we do outreach? How do we communicate with them? How do we educate them? How do we align them before we even start talking about processes and technologies in order to begin sharing information on a daily basis? Should your organization step up and say, you know, we're the 300-bed regional medical center. We are taking value-based purchasing hits, 30-day readmission hits. It's costing us money. Our HCAP scores aren't doing that well. Is it worth your while to take the lead and step up and become the anchor facility? Are you leading the charge to become the center of an ACO or a shared risk network? Then it's worth your time and your investment to really take the lead and provide these services to your partners, because they truly are your partners, your care partners, whether in your network, out of network, or the community. Should that be? That's a very strategic question. Should that be your organization, or should you encourage somebody else to step up and do it? And are you really thinking across the community? It's easy to say, yes, we help in the community, but are you really understanding coordinated care at the episodic basis across the community, across your network, out of your network, all the providers, the patient goes where they want to go? Are you really thinking all-inclusively? It's a holistic mindset. And it's, again, a very strategic viewpoint. And it's one thing to say it, it's another thing to do it, and it's another to really commit to it. So do you really want to be a community coordinated care? We believe it's the only way to succeed going forward, but whether your organization wants to embrace it or avoid it or deal with it minimally, there's a lot of different ways to go there. So in conclusion, there's an old joke that says, how many psychologists does it take to change a light bulb? And the answer is none. It has to want to change. And that is an old joke, but it is meaningful. You can get a lot of data, a lot of research, but until your organization really wants to change, understands the impact, care coordination, to double down on it, to really commit to do well at it, to get somebody to own it, to look at what you're doing today, beginning with the discharge process, to understand that this has an impact on your patient outcomes and your care scores, cost impact, the revenue impact, a lot of impacts. Care coordination is one of the keys to succeeding in 21st century payment reform. Can you make the changes? Can you enforce the change? This is cultural. Can you sustain the change? Can you be honest about the as-is process? It is rarely pretty. Can you be honest about it? And can you be honest about the results? Are you willing to try and to fail and to try again and to measure and adjust in order to make this better? Are you truly committed to it? We think that those organizations, those forward-looking organizations that want to succeed, that realize they don't have a choice but to go forward with this, are the ones who are going to make out. And finally, very simple. We believe in a quick six strategy and a strategic six, and that will lead you into other places that you probably didn't think you would be going at the beginning of the journey, but are worthwhile going because you're showing you can understand the impact they're going to have on patient outcomes and on financial outcomes. So that's it in a nutshell. We will be glad to take any questions, and also please feel free to contact me. My information here is on the right-hand side. Love to have a discussion. Love to understand where individual organizations are in their journeys and how we might be able to help or talk through some of the issues. So please feel free. Thank you very much and have a good rest of the day.